Great, we're going to go ahead and get started. Thanks everyone for being here. So for grand rounds today, we are in for a real treat. We have two wonderful pharmacists who are going to be here presenting to us on key pharmacy issues in HIV. Jennifer Cocohoba, who's coming over from the UCSF Women's HIV program, and then Janet Grochowski, of course, who we all know and love from Ward 86, will both be presenting. So just a quick reminder as we're getting started to text this number for your CME credits. And then we'll go ahead and get started. So Jen, come on up.
Matt, for that fantastic intro. Good morning, everybody. I think I speak for Janet and myself to say that we're both happy to be here today to be focusing on the topic at hand, which is precision prescribing. So we're going to go through some cases related to HIV pharmacotherapy. And as Janet and I were preparing our talk today, we thought we would informally retitle our presentation, actually, Not So Precise Prescribing, as you'll understand as we go through some of the cases where sometimes as we try to be as precise as possible with HIV pharmacotherapy and their interactions with others, it is not as easy as we would like it to be. So these are just a couple of the objectives that we're going to be focusing on today. You can read those at your leisure. And then why don't we go ahead and launch into the first of two cases for today, which I have titled A Tale of Two Amlodipines. So this is one of our patients who's a 67-year-old trans person with past medical history of HIV, hypertension, hyperlipidemia, anxiety with a lot of agoraphobia, and has been treated for hepatitis C in the past. This person was diagnosed quite some time ago and has had some struggles with their antiretroviral therapy, has been on various regimens, including Atripla in the past, various combo regimens, more up to speed as of late, was on the combination of tenofovir, emtricitabine, and bictegravir with, unfortunately, intermittent adherence, was really, really excited to get on long-acting therapy, and so we started long-acting cabotegravir with rilpivirine, did okay for a couple of months, and then the E127K emerged, and so this person actually failed on long-acting cabotegravir with rilpivirine. So we were back to square one, trying to find a regimen that this person was able to tolerate, and tried a few. Lots of GI distress, kind of feelings of subjective weakness for this person. So we landed on sort of an unusual combination of orals with a long-acting injectable, which the person had bought into, which was drunivir-cobi, once daily, doravirine once daily, because that was what the person was able to stick to, was a once daily oral regimen, with lenacapavir every 6 months. And you can see the medication list to the left side, which was quite hefty for this person who was struggling with their adherence. So here's the timeline. Here's a timeline of events. So in October of 2023, the person had their first lenacapavir injections. I gave them a call. The next day, they were doing okay. So, just a little bit of soreness, feeling all right. They actually had a scheduled appointment 2 days later, but they actually missed that scheduled appointment. And that was just to eyeball them and kind of hold them very closely after this regimen change to try to set them up for success, but that didn't happen. They were scheduled for a visit with our psych NP, and they did have that. They had that via telephone because they are unable to do Zoom visits. And so at that point had been mentioning just overall low mood, low energy, which was not that unusual for this person. That had been sort of a consistent symptomatology over this person's tenure for the last couple of years. On the 1st of November in 23, the person called in, was experiencing nausea and weakness for about a week, actually visited the ED, got IV fluids, and then felt better, so went home after that. We saw that person a week later in clinic, and the person was still feeling really drowsy and dizzy. And upon measurement of blood pressure, we found that the blood pressure was much lower than their usual, which was high. So they typically ran above goal. The person was afebrile at that time. So I'll pause here and ask you your thoughts. Let's take a quick poll and answer, what do you think is the likely cause of this person's sort of newish onset symptoms? Do you think it's depression, a viral illness that maybe is brewing, lenacapavir adverse effects, some drug interaction, or I don't know, could really be anything with the multiple morbidities that this person has? I think we've given it away, given by fact that we are pharmacists that are presenting to you. So I think maybe we thought perhaps this was a drug-drug interaction. So I think we've been spending a lot of time in HIV grand rounds over the last several weeks talking about lenacapavir, which we all know is our capsid inhibitor that has multiple mechanisms of action on the HIV life cycle. I think we've also probably in past grand rounds discussed its metabolism, and it's a substrate of the ubiquitous cytochrome P453A4, also of UGT1A1 and of P-glycoprotein. I think we also know that it is a moderate inhibitor of cytochrome P453A4, and it can potentially impact medications that have been prescribed or administered anytime within a large time frame of 9 months of the administration of the injection. Because it hangs around so long, its drug interaction potential also hangs on a really, really long time. So with all that, I want us to just take a quick step back and think about the issues around polypharmacy and HIV. I just, as always, kind of refreshed my memory, and so went to my PubMed to look up what's the latest and greatest around polypharmacy and HIV. And I think even in just the last couple of years, there were 49 publications on polypharmacy and HIV just in the last couple of years. At the intersection of those things. And I think we know that these studies are both informative as well as sort of challenging to synthesize. And that's because there are in these studies, no standard definition of what polypharmacy is, right? Sometimes it's 5 medicines, sometimes it's 3 medicines. And then looking at the studies that are focused on HIV and polypharmacy, some of them include antiretroviral therapy as part of the count of polypharmacy. Some of them don't. So, it tells us a lot. These studies can tell us a lot. At the same time, they're not very standardized. So, kind of have to think about what the studies are, what the populations are, and what the definitions are to think about the impact in these populations. I think the truths that do seem to rise out of these studies, I think we recognize that people with HIV probably do take more medicines than their counterparts of people who do not have HIV, although the exact estimates, again, because of the lack of definition in these studies, are hard to pin down to exact estimates of what proportion, how much more. I think we also recognize that there are commonalities in terms of external factors that seem to contribute to the rise of medications in these populations. Everybody's aging. With aging comes more medicines. With aging often tends to come multimorbidity, although we see that more frequently in people with HIV. So that part is common. And I think it's also just to take a good reminder that what we're worried about with the drug interactions is the impact, right, on renal, cognitive, frailty, all of these issues that can be potentially harmful for our persons as they age with HIV or without HIV. What are the impact of the combinations of these medicines in a way that is detrimental to our patients' health? And I always put this last little bit there as well as, sheer numbers are not necessarily alarming, right? Not all polypharmacy is inappropriate. Some of it is inappropriate, but not all of it is. If we are adequately addressing conditions, people are feeling safe, parameters are within goal, then, unfortunately, as we age, we get more medicine. So there's a lot to consider with polypharmacy and HIV. So going back to our medication at hand, so with lenacapavir, I just wanted to place this up here as well. And so you can focus on the text in the red. This is a comparison of the text from the product package inserts for both lenacapavir for HIV or Sunlenca, as well as lenacapavir for PrEP, which is Yeztugo. And you can see here kind of the stuff that we've already talked about, that it's a moderate inhibitor of CYP3A. It can increase the exposure of drugs that are metabolized by CYP3A within this 9-month time frame. And so, you have to worry about potential adverse reactions. And so that's actually consistent, although maybe a little bit more concisely written in the Yeztugo label. This is a list of the top 50 prescribed drugs. And so again, with the disclaimer that top 50 prescribed drugs can be number of prescriptions, number of sales, et cetera, et cetera. So this is just one list of the top 50 prescribed drugs. The last time this was updated, I think, was 2023. So it's the 37th edition of the top 300 prescribed drugs. And probably lots of these drugs look very familiar to you because you're using them a ton. I also just wanted to highlight of these top 50 drugs, the drugs that I've just changed to purple or red are drugs that are metabolized by CYP3A. So you can see a bunch of them actually light up with potential interactions with inhibitors or inducers of cytochrome P453A. So what's the difference between purple and red? The red medications are ones that are considered sensitive substrates. So their major pathway of metabolism is through cytochrome P453A, or the potential impact of changes in levels of these medicines is concerning. So again, I did this as an exercise just for fun. And I was like, oh, look at all these medications that are metabolized through cytochrome P453. So lots of commonly prescribed meds that have lots of potential impacts with some of our newer HIV therapies. All right. And then you can see my circle there. There's amlodipine. So I'm right. All right, we've got it. Look, I found a drug interaction. So I was really excited, was talking to the person's provider and I was like, I think I have it. Look, there's a blood pressure and I found amlodipine. Look at this stuff. So, we looked it up together on our trusted Liverpool website. I'm like, look, see, possible. It's a possible interaction. Of course, there's no evidence behind it because it's not been studied, but theoretically, this could actually happen. All right, so here's what happened. After that, we're like, all right, I'm going to change the dose. So we dropped the amlodipine dose. And then our person did what she always does is like, there's a lot of intermittent adherence to all of the medications. And then somehow in some other sphere, because we have multiple clinics and multiple people seeing our folks, the amlodipine dose was increased again. And then just life happened for this person. They were really excited to get a revision of keloids on their neck. And so we're preparing for surgery. They had to do a cardiac clearance. They got a cath. There was occlusion. They got a stent. So there's just all this stuff, poor thing, happened to this person. And so you can see here, in all this, and then of course, person missed their medication reconciliation appointment with me when I was supposed to kind of look at all the drugs that they had and what was prescribed and what was at home. So I'm hoping they come for the appointment that is actually going to be this month. But you can see here sort of the history of the clinic blood pressures. Look, they look pretty normal. And so that is also in the setting of having somewhere in there, their amlodipine dose was increased back to 10 milligrams and sort of didn't budge from there after. You can see February 2025, there was really no change. So we're like, what's going to happen there? I want you to hold that thought. I just wanted to point this out as well, which I think was discussed 2 grand rounds ago, that our person is also on estradiol. And we have been reassured that there are no interactions between lenacapavir and gender-affirming hormone therapy. So that one was a clear. But hold your thoughts about amlodipine, because I actually want to talk about another amlodipine case. So this is another person who actually was infected at birth. She's a 37-year-old female with HIV, hypertension, asthma, follicular lymphoma, lots also of challenges with adherence. And so, really infected at birth. And so lots of, our favorite 2 drug regimens, progressing through PI therapy, et cetera. And so we landed on, a long time ago, this unusual regimen. There was NRTI and INSTI therapy. Then we switched to this, basically an elvitegravir, Cobi, and darunavir, sort of kind of trying to combine all of the medications to simplify therapy so that it was once daily for this person, and kind of hung out there because she has a lot of resistance mutations. So she was really excited. She wanted to go on long-acting cabotegravir with rilpivirine, but could not because she had resistance to rilpivirine with a Y181C. And so we were waiting. And then we decided to do triple injection therapy with cab, rilpivirine, and lenacapavir. So she's ready to go, was really excited about this. And so I screened the medication list before we got started on that regimen. I was like, look, it's amlodipine. So, favorite fishing lure, asking you all, when you screened that medication list and saw the amlodipine, what would you do? Nothing? I wouldn't have been thinking about the amlodipine. We'll just leave it the same dose. maybe I should go ahead and decrease the dose, or would you hold off on LAART? So a little split. So we have some folks that are like, no, let's leave it. And a couple of folks are like, oh, we're going to preemptively decrease the dose. So I was like, I found another amlodipine. I'm going to go ahead and decrease the dose and avoid any adverse effects in this person, because she was also very sensitive to adverse effects and was sort of worried about her, et cetera. Right or wrong, this is what we did. All right, here you go. So here's the timeline of non-events for this person. So again, kind of first injections, I was like, yes, I'm going to decrease the dose of amlodipine. We're going to avoid adverse effects on this person. Called, was doing okay, had some injection site reactions, was otherwise doing fine. And then life happens. So was having difficulty picking up her medications, couldn't afford the copays as well, was just struggling to get to the pharmacy. We tried to switch to different pharmacies, et cetera, et cetera. Again, sort of split care is seen by hypertension disparities program and got increased back to the normal dose of amlodipine, still having to this day insurance and medication adherence challenges, was hospitalized for a viral illness at one point. And then you can kind of see here the timeline of blood pressure and events. And so starting the injections in February of 2025, kind of going down, not kind of up and down in terms of kind of blood pressure control. You can see sort of an increasing way above goal here, 153/97, et cetera, et cetera. And so on 6/25, I basically handed her amlodipine. It was at the 10 milligram dose because that was what she had been prescribed for hypertension disparities. And woohoo, look, she's at goal at that point. And then we're back to October where we're not at goal again. So up and down. All right, so what the heck is going on here? I think there's a lot going on here, right? So when it comes to drug-drug interactions, there are a limited number of studies, right? We have PBPK modeling, which can kind of help try to predict what's going to go on with these, but it's just nearly impossible to study every HIV antiretroviral with every top 50 prescribed drug. So we have to do our best to predict and then kind of decide what we're going to do in terms of management based on a couple of factors. What's the likelihood of the interaction? What is the therapeutic index? If the person gets more, in this case for lenacapavir, if the person gets more than we think that they're going to get from a standard dose, what is the potential clinical impact of that? Is it going to be dangerous? Is it not so dangerous? Is it something we can monitor? And then also sort of the patient, right? Are they going to be able to be in touch? Am I going to be able to contact them to figure out if they're having adverse effects? Are they going to come back in? So all of these factors are swirling around as we're trying our best to predict what the interaction is and how that's going to impact the patient and how we can manage the patient. So it's all these external factors that have to be incorporated into the decision to adjust versus not adjust the medication. And we're always weighing the risks and benefits. So, it's a ton of monitoring and you sort of do your best, but all of that comes into play. Another little kind of the DDI saga continues for this person, same person, my second amlodipine lady. And so, if you had been looking at her drug interaction list, you might have also seen that one. So she is also on ICS LABA for her asthma. At that time, she was not using the medication. So I was like, okay, great. No worries about a drug interaction. But at the last visit, I talked to her. She's like, I should start using my inhaler again. I was like, oh, okay. Let's figure out what we're going to do with this, because that is also in the top 50 prescribed drugs and has potential for increased levels with her lenacapavir, which was just administered fairly recently. So I haven't dealt with it yet, but I'm going to deal with it soon. The last thing I'll just kind of talk about is we focused on the impact of lenacapavir on other drugs, but also there is the impact of other drugs on lenacapavir. And so if you'll take a look at the text in the red, we're looking at the labels for Sunlenca versus Yeztugo. With inhibitors, it is the same. So looking at sort of the middle row, the text is basically exactly verbatim the same. So with inhibitors, you have to worry about potentially increased concentrations of lenacapavir. And so in general, the company does not recommend strong inhibitors with lenacapavir because you're just more lenacapavir. But if you look at the text that's associated with inducers that can lower the levels of lenacapavir, there is actually a difference between the labels. So with lenacapavir Sunlenca, it says contraindicated. So they don't want to risk any loss in lenacapavir from an inducer. With Yes2Go, they just say, okay, well, you can give supplemental doses, and that should fix the problem with when you're using it for PrEP. And so in some ways, it sort of makes sense, right? There's a higher risk. If you're losing lenacapavir in a person who's being treated for HIV, that could be potentially very bad because we want lenacapavir at full power. I would argue that I'm also worried that person has adequate levels for protection against HIV for PrEP, but studies have been done. So here they are. So in terms of where that data came from, it's actually from modeling data. They utilized 2 medications as their tester medications or input as their tester medications. So rifabutin is a moderate inducer of CYP3A4. Rifampin, as we know, is a strong inducer of CYP3A4. And so they sort of modeled the levels of lenacapavir when given with rifabutin. And this sort of led to their conclusion that, okay, it's okay to just go ahead and give a supplemental dose. So with a moderate inducer, you just give 1 injection, the half injection. And then with a strong inducer, rifampin, they recommend giving the full dose as a supplemental to make up for any loss in medications. Interestingly, this was accepted by the US FDA. So we're like, yeah, no problem, supplemental doses. We'll put that in the Yes2Go label. But the European Medicines Agency decided that was a no-go. So it's not in the EMA label. All right, so just kind of wrapping up with the tale of 2 amlodipines, it was a lot. So not all drug interactions are alike. I think we know that. These 2 cases have just reminded me how much real world life just gets in the way of perfect prediction of drug-drug interactions. And then just, thinking about our len for PrEP, we always think, oh, these are our young, healthy folks, but they are on medicines too. So, and probably the top 50 prescribed drugs. So really just need to take a look at what their medication lists entail to see if there are any adjustments or potential adjustments that need to be made for these folks. And so we are here, obviously, message your friendly neighborhood Spider-Man pharmacist, always happy to wax poetic about what the potential interactions can be, even if we don't have precise answers for you for prescribing. And then before we switch over to Janet and your credit, enjoy a haiku by ChatGPT.
Hi, thanks. And thanks for that great review of overall drug-drug interactions and polypharmacy. I really appreciate it. I'm just going to focus more on my actual cases. So let's move to the first case. And I'm going to talk about drug-drug interactions with cabotegravir, rilpivirine, long-acting injectables. So case number 2, we have a case of disappearing methadone. So 58-year-old male, opioid use disorder, living with HIV, has treated hepatitis C, lower urinary tract symptoms, osteoporosis, anxiety, status post C2 through 6 posterior decompression, and instrumentation cervical stenosis. His medications listed there on the left, no potential for methadone interactions. On 11/15/2022, he started on cabotegravir, rilpivirine, long-acting every 4-week dosing. In March 2023, he got switched to the every 8-week dosing. And I'm happy to report his HIV has been virally suppressed throughout treatment. So in April 29, 2025, so about 2.5 years since he started Cabril, we got a message from Ward 93 saying that they happened to notice some low levels of methadone in a client who happens to be on rilpivirine. They've seen low levels before, but this is the first one where someone's also on the injectable cabotegravir rilpivirine. So they reach out to me and ask me about this, and they give me the information that they have. They've actually done low serum peaks and troughs of methadone in this patient, and these were drawn after the patient received 5 witnessed consecutive methadone doses of 200 milligrams PO once daily. So in the left column, you can see the patient's methadone levels. It had a peak of 362 nanograms per ml, and that's actually comparing to what they would have expected on this dose of methadone of 1,500 nanograms per ml. His trough was 159, and expected was 900. They did calculate a half-life of 17.2 hours of the methadone, when we would expect methadone to have a half-life of 24 hours. I'm really impressed that the methadone clinic can do this. I wish we could do this with cabotegravir rilpivirine, and that they know how to calculate half-lives. So the question was from them, are these low methadone levels, are these due to a drug-drug interaction with cabotegravir rilpivirine? So this is my first audience response. So yes, rilpivirine is an NNRTI, and that class tends to be CYP3A4 inducers. B, yes, CAB is a known CYP3A4 inducer and has been shown to decrease levels of CYP3A4 substrates. Both CAB and rilpivirine are both weak CYP2B6 inducers. So when you combine those two weak inducers, of course, they're going to decrease the levels of methadone. And then no, CAB, rilpivirine are not inducers and do not decrease the serum levels of other medications. Ooh, good spread. Thanks. All right. So let's move on and find out the answer. So let's just quickly review cabotegravir metabolism. So cabotegravir is a substrate of UGT1A1 and 1A9. And what that means is that inhibitors of the enzyme UGT1A1 will increase the levels of cabotegravir. Inducers of UGT1A1 or UGT1A9 will decrease the levels of cabotegravir. When they were studying cabotegravir, they did look to see if cabotegravir impacted other drugs, and they found in vitro studies that cabotegravir is unlikely to impact the pharmacokinetics of other drugs via drug metabolizing enzymes or transporter pathways. So this may not be our answer. What about rilpivirine? So rilpivirine is a substrate of CYP3A4. So once again, if we have an inducer of CYP3A4, rilpivirine levels will go down. Inhibitors will increase the rilpivirine levels. And rilpivirine's been around for a long time. There's been lots of drug-drug interaction studies, and they found that rilpivirine doesn't inhibit or induce or have an effect on drug metabolizing enzymes or transporters. So it looks like rilpivirine isn't the answer. But this question has come up previously about methadone and rilpivirine, and that's probably because efavirenz, an older NNRTI, would decrease the levels of methadone. So when rilpivirine came out, they did do studies with methadone. So this one's back from 2014. It was an in vitro study that rilpivirine at supratherapeutic doses was a weak inducer of CYP3A4 activity. So in these clients that were on stable methadone doses, they gave them rilpivirine, and you can see the black dots are the levels of the methadone after giving rilpivirine. And what they found is that the methadone levels at supratherapeutic doses, so 75 milligrams to 150 milligrams instead of 25 milligrams daily, reduced methadone by about 16%. These patients didn't have any withdrawal effects. They didn't have to change methadone dosing. So rilpivirine is not the answer. So is this due to a drug-drug interaction? No. So I talked to them at Ward 93. There is some pharmacogenetics that's probably at play here. So they do see sometimes people will have lower levels of methadone. The answer for this pharmacogenetics, I did do a quick literature search. It hasn't been, the genome hasn't been discovered yet. They think it might have to do with that 2B6. I don't know if anyone's here from Ward 93 if they have any more answers. Okay, so talking about, we want, since cabotegravir, rilpivirine are injectable medications to suppress HIV, we want to make sure the levels stay at an effective level throughout treatment. So we are worried about drugs that will decrease the levels of cabotegravir and rilpivirine. So as a reminder, UGT1A1 inducers will decrease cabotegravir. Some famous ones are rifampin and phenobarbital. And then CYP3A4 inducers will decrease rilpivirine. So rifampin and phenobarbital do both. They induce both those enzymes. And then carbamazepine, phenytoin, the older anti-seizure medications will also reduce them. This on the right-hand side, this graph shows in actual subjects, cabotegravir with rifampin. You can see the levels of cabotegravir in that purple line. They go down by about half. And then here's a modeling study just as a demonstration so you can see what we expect to happen if someone's on injectable cab or rilpivirine. If you give 600 milligrams of rifampin every day, the levels shown in blue is how low the cabotegravir and rilpivirine levels will go down. So we're not going to be combining rifampin with cab rilpivirine. Okay, this is a review of a case that I went through a couple years ago when I presented. So phenobarbital, we just talked about, can decrease rilpivirine and cabotegravir. So you probably know the answer to this one. A 59-year-old patient living with HIV on cab-ril was seen in the ED for acute alcohol withdrawal. And what would you recommend? Administer phenobarbital, administer diazepam, or why would we talk about these legacy medications? And I'm going to go through this one quickly because we've done it in the past. Oh, interesting. Okay. And then I once again just checked to see if there's any more information about the drug-drug interaction with cabotegravir and phenobarbital since I presented this last time, and no. So this is what happened in our patient. So he started on cabotegravir rilpivirine every 4 weeks in November 2022 with a detectable viral load. And as we have seen with our patients, a month later, they're undetectable after starting the injection. He was seen frequently to get phenobarbital in the ED because of alcohol withdrawal. So that the first dose was done in February. We were checking his HIV viral load, I think, every month because we had just started the injectable HIV program. 11 days after that phenobarbital, his viral load was less than 30. In March 2023, phenobarbital again. May 2029, phenobarbital again. And then a few days later, he happened to come in because he was due for his cabotegravir rilpivirine, and we're going to give him the higher dose and switch him to every 8 weeks. We checked the viral load because that's what we were doing at the time, and the viral load was a little bit of a blip of 36. Then June 16th, he received 2 doses of phenobarbital. He was in the clinic 14 days later and happened to get a viral load, and there was a big blip. So after I presented this case, we actually changed the drug-drug interaction in EPIC when people are admitted at SFGH. And what happens is that if someone tries to prescribe phenobarbital with cab-rilpivirine, another extra drug-drug interaction note will come up saying, are you sure you want to do this? Just so that there's a little bit more people thinking about the drug-drug interaction rather than just the normal one that comes up and everyone ignores. So the answer, I checked with the ED providers, it's diazepam. So if we can't use phenobarbital in someone with alcohol use disorder, I guess they use diazepam. So I'm still hoping that people avoid phenobarbital with cabotegravir rilpivirine. I don't know if anyone else has more information on that or if they've seen more. I know we put together a paper for CROI to look at all the times that phenobarbital were administered at ZSFG with cab rilpivirine plus any oral ARVs. Okay. Going to move on to what happens when we see a new drug in clinic. So this actually happens to be the same patient. It's June 2025. He's now 61 years old, 2 years later, no longer drinking alcohol. Yay! Continues cab rilpivirine every 8 weeks. His viral load has been less than 30 since that blip of 106 in 2023. So on June 18th, 2025, he calls the clinic. He's like, I have some new lower back pain, shooting right leg pain, and I tried taking my baclofen and gabapentin, and it didn't help. But I have a friend and he gave me some suzetrigine 50 milligrams and I'm feeling much better. Would you prescribe this for me? So would you prescribe suzetrigine for him? Yes, you've seen the commercials. It sounds amazing. And no, you don't feel comfortable prescribing this medication. You recommend ibuprofen and acetaminophen and referral to PT. Oh, okay. Well, let's talk about suzetrigine. So the mechanism of action is a selective blocker of the sodium voltage gated channel. It supposedly inhibits transmission of pain signals from the periphery sensory neurons to the spinal cord and brain. The dosing is 100 milligrams followed by 50 milligrams every 12 hours for up to 14 days. And the indication is treatment of moderate to severe acute pain in adults. And it was approved by the FDA, and the approval was driven by 2 phase 3 placebo-controlled double-blind randomized trials that demonstrated statistical significance with superiority in treating pain after bunionectomy and abdominoplasty. So very appropriate for back pain. So 6/18/2025, suzetrigine was prescribed by the PCP. It wasn't covered, it needed a prior authorization, and I got it approved. And then on 6/30/2025, patient messages the clinic about refills on gabapentin. And then I remember, shoot, I meant to look up suzetrigine to find out more about it. So I reach out to the pain management PharmD from San Francisco Health Network to see if she knows anything about it, because that would be a quick way to find out some information. She's like, it's not on formulary, so we don't prescribe it. I don't know much about it either. So then I did a Google search, and on the manufacturer's website, as you scroll down, it ends up that suzetrigine is an inducer of CYP3A. And they even say, if it's used concomitantly with CYP3A source substrates where minimal concentration changes may lead to loss of efficacy, dosage adjustment of that CYP3A substrate may be required. And that means rilpivirine, right? Because rilpivirine is a substrate of CYP3A4. Suzetrigine, according to Lexicomp, is a weak CYP3A4 inhibitor, but still, we don't want any of that with our CAB and rilpivirine, especially our rilpivirine. So 6:30, I call the patient. He says he hasn't taken the suzetrigine in a few days. He'll destroy the rest of the tablets for me and come in for a viral load. And I'm happy to report that 11 days after being on suzetrigine, his viral load was less than 30 and it's remained there. So the answer is no, do not prescribe that. Okay, and then the last case is a case Jen helped me with. She shared this case with me. 50-year-old female with HIV, hypothyroidism, renal insufficiency, and insomnia. In 2009, she had a positive PPD test. She was treated with isoniazid, but had a drug-induced liver toxicity. She's had annual x-rays for TB clearance for methadone program. And the question is, should we try to treat her again? You see her long ART history, but she's been on CAB, rilpivirine, long-acting since 2022 and is stable and has a pretty short med list besides that. So the question is, should we treat her latent TB? Yes, the regimens are so much easier now. No, it's too risky given her history and her long-acting antiretrovirals. Maybe we might have to get creative with her latent TB treatment and or ART regimen. So what would you guys decide? It's been 2009. TB has stayed latent. Okay. So this case, it forced me to actually look at all the recommended latent TB treatment regimens. And these are the ones from the CDC, and then also DHHS guidelines also mentions all of these. Some of them are preferred based on the guideline versus alternative, but these are the ones that we could use currently. And I put down the abbreviations because I always forget those. I put the frequency because I always forget those, and the duration. So now I can always go back to this chart whenever anyone asks me. So in this particular patient, she can't take isoniazid. So because of the liver toxicity from it, the only option would be to do rifampin for 4 months and for her to take it daily. But with CAB rilpivirine, you can see rifampin and rifapentine. You can't give those if someone's on CAB rilpivirine because we expect those drug levels to go down. Her only option would be, if she stayed on her long-acting, is isoniazid. And we also have that same issue with lenacapavir. And then just as a reminder, we talked about this earlier in that if we give 600 milligrams of rifampin with cabotegravir rilpivirine, the levels are going to go down. So not an option to keep her on injectable ARVs plus treat her latent TB. So I made up a table of the easiest oral regimens that you can administer with all the recommended latent TB treatments. Efavirenz and raltegravir can be used with rifampin, but I don't think many people would want to use those. So I've just done this for myself so that I have like a cheat sheet if anyone asks me in the future. For this individual, this woman, her only option would be rifampin. So what we would have to do is on her next injection date, she would have to stop the CAB rilpivirine, start rifampin daily, and take dolutegravir twice a day with TDF-FTC. And she'd have to continue on that for 4 months with the rifampin, and then continue on that oral regimen for at least 2 weeks after the latent TB treatment. And I would actually recommend going 4 weeks just because we've had someone fail after starting CAB rilpivirine and after 2 weeks after stopping rifabutin. So I would be on the safe side and actually go 4 weeks. And then plus she's going to have a full bottle from the pharmacy anyway. So that would be the option in this particular patient. And then I threw TAF up here because I'm kind of curious. I'm curious if people in other clinics are using TAF. it's not FDA approved. There was one in vitro study showing that tenofovir diphosphate intracellularly when TAF is given with rifampin is higher than the intracellular tenofovir diphosphate when given with TDF. So the levels may be there if we need it. For the rifapentine, they gave BIC TAF FDC with isoniazid and rifapentine daily for a month, and patients stayed virally suppressed, but that was only for a month. That's not this 3-HP dosing. So I don't know. I'm not recommending TAF, but it is an option and maybe it works. I think there's a study ongoing now, a clinical study about it. And so should we treat her latent TB? Maybe. I mean, I think it's one of the art of medicines, talking to the patient. If she's willing to go off injectables, go on oral pills for 4 months, 5 months. And so in conclusion, we want to remember to protect cabrylpilvirine LA from medicines that are inducers. Be aware that new medications have drug-drug interaction potential as well. Scroll down the whole patient or the manufacturer website to find out all information. And unlike lenacapavir, cab and rilpivirine do not alter the levels of other medications. And you can always message your friendly neighborhood pharmacists. And the haiku here, I didn't realize, Jen, it was the same. Oh, sorry. Yeah. Great. And and we're ready for questions. Thank you.
Janet and I talk really fast.
That was so good. I wanted to ask what you thought about the lenacapavir, the claims that you can use rifampin and with lenacapavir with the extra oral doses if it's rifampin, the half dose of injectable if it's rifabutin, and what is that based on? All PK in enough individuals? Do you feel comfortable with that data to use those two inducers with rifampin, with lenacapavir?
No, and I have to say, why did the European guidelines say that they didn't agree with it? And so I don't trust modeling data as much as I do real world data. So, and then also like asking the manufacturer or asking the insurance companies to pay for an extra $14,000, right, of lenacapavir for when somebody could just take isoniazid or change their change their dose. Yeah.
With TB treatment. I mean, I'll give the other side of it as well. Not that I would actually, we haven't done it yet in any of our patients. We don't have to treat active TB that often in our clinic. But this is also sort of the way that things are going, right? You know, drug-drug interaction studies are expensive to run and difficult to run with lots of different medications. And so we are going to be seeing, we are already seeing a lot of these interactions based on modeling data. Do I trust it 100%? Probably not, just because, you know, I'm old school, right? I like drug interaction studies that are that demonstrate levels in actual people with, you know, variability. But, you know, I think it's a question that philosophically in pharmacology we're going to have to grapple with, because this is what we're going to be seeing are these PBPK modeling studies for drug-drug interactions.
Just a couple comments related to latent TB and active TB, just because I see several of us see co-infected patients and with HIV and TB in the TB clinic. One point, Jan, just to add to that list, not yet on the guidelines for LTBI, but there are a couple trials now of levaquin for LTBI treatment, so prevention of reactivation, and both in adults and kids. I think it was Vequin and Champ are the two trials. It's something you could consider, particularly in a patient like that, where you really get boxed out. So just thinking of options like that. The other point just to make is if someone has struggled with oral medication adherence and we're treating them for TB treatment, they're typically getting DOT, kind of like our patients who go to Ward 93, where they're getting their medication. So it is an option just to discuss with the TB clinic. I don't want to speak for them, but for the nurses, they can help with co-administration if your concern, if the adherence is the main reason that they're on an injectable regimen and they need to be switched to an oral ART regimen. So just a couple points there. Thank you.
I think those are great points as well. And also bring back the Levaquin thing, because we were just talking about this last week and we're like, what should we do for this person? So that's a great suggestion. Thank you.
Okay, great. I'm going to take one from online. Back over here. Okay, so for asking about this last case, for people in this situation, how do you weigh the risks of change in ART versus the benefits of treating the LTBI? Would you consider not treating the LTBI in this case? Or is her reactivation too high? So what do you think about that?
Yes. So yes and yes. This is actually the very discussion that I was having with the provider as we were trying to determine, what is the risk of reactivation, right, with LTBI, and a person who has a very strongly stable immune system, stable on ART, and so that is certainly one of the options. It was actually where we walked away. At the end of our discussion is maybe not, sort of kicking, we called it, let's kick the can down the road for a little bit longer, which actually now we have potentially trial data that are going to help us with other options, which may be safer for this person. So I think really weighing the risk, what is the risk of reactivation? There's some data around risk of reactivation in people with HIV versus people with not HIV. In terms of this particular patient's concerns, we felt that would be okay to wait. To treat given the severity of her reaction to isoniazid.
And then a follow-up to that, what would your monitoring strategy be during LTBI treatment for this person?
Oof, good question. You have an idea. We, to be honest, have not thought that far because we were going to kick the can down the road in terms of treating her for LTBI, but certainly kind of depending on what we would decide to do. This, and again, there's a lot of factors that weigh into this discussion, right? Kind of, I don't like saying stable, but sort of how engaged the patient is. And this patient is very engaged in her treatment, has good health literacy as well. And so I think this person would be very aligned with frequent monitoring. But if we were going to go with sort of traditional methods, we'd have to, not with a Levaquin-based therapy, we'd have to switch her to orals. And I think she would do very well with adherence to a new oral ART regimen. And so monitoring, I think, would just be probably 2 weeks after start, and then monthly through the therapy would just be my sort of off the cuff thought.
I have so many questions for you because this is a really good talk and I really appreciate your expertise, both of you. So one question I have on the new formulations of lenacapavir and cabotegravir, I am with lenacapavir, cabotegravir, the ultra long acting formulation. Do you think that PK studies are adequate to determine if they can go into just clinical practice, every 4 months, cabotegravir for prevention with PK alone? And the second, and it's related to that, is do we really know the protein adjusted, 4 times the protein adjusted IC90 of those medications? Like how is that determined? And then there was, those are the 2 main questions, but I have another one.
Your thoughts on ultra long acting?
I think if the PK data was done in actual subjects, I think I would feel pretty comfortable with it. Yeah, if it was just modeling, no, but if they've done it in actual subjects, then yes. And then I would guess I would also like to be, I would imagine that the manufacturer could push for CAB levels to be done in clinic, right? I mean, this is something that should be a progression of these medications so that we can keep a better track of what the levels are, what if people are breaking through with PrEP or if they're breaking through with their HIV,
I mean, I think of all the medications, long acting lends itself to levels because you can shorten the duration or prolong the duration, and you can make the dose smaller or increase the dose. I mean, we can't dose adjust darunavir, but we can dose adjust both in duration and actual dosing the long actings.
I think we're all very excited, right, about sort of these ultra long acting formulations. The less administration, the better. At least that's what our patients want. That's probably what we want to from a clinic workflow standpoint sort of helps us get more things in. I think there are a lot of questions though in terms of what's adequate in terms of data, right? Can we just extrapolate from, for example, like Q2 month data to Q4 month data for ultra long acting CAB, or what's going to be acceptable in terms of, okay, well, approval will be based on all the drug interaction studies, of which they weren't actually done because they were done with orals for cabotegravir and rilpivirine and sort of translated to the few studies that were done with the injectable. So understanding that there is going to be some element of extrapolation, but I think, all of us are much more comfortable with like hard data in actual patients. And so, that will be a call for lots of things. I think, the devices that are under study to have these, CGM type, the wish level of being able to get a level of some of these ultra long acting medications through a small, easily handleable device would be something I think that would be very helpful for monitoring therapy, as Janet has said.
And then I have another comment because I actually haven't looked at this, but for the long acting antipsychotics, a lot of them have moved from 2 to 3 to 6 months. And I haven't looked at how those were approved. Do you happen to know where those just done on PK data? Yeah, so I don't know. Like that would be interesting to find out, but also the levels of the antipsychotics. There's a much larger therapeutic window than there is for rilpivirine, but we could get an idea if that's what's been happening with these long acting injections.
That's an antiviral. If you're a little bit low, it doesn't meet resistance, So there should be something very stringent.
Yeah, and I have to say the long-acting antipsychotics, I always get nervous when people start to go on the every 3-month one because it's more likely that they will fall off of treatment because no one will notice that they didn't come in for their injection. And I've seen them fail more than the people that are coming in every month.
That's a great point. It all depends on the supports. Yeah. Just another comment from online, Dr. Aisha Appa, just echoed what you said about phenobarbital, that certainly we want to avoid that co-administration with Cabril. However, she also mentioned that in a big chart review of all the charts of people who receive phenobarbital, people who only received 1 dose all remain virally suppressed. So just to sort of add that comment in, we need more data on this certainly. Okay, I'm going to add another question. So Jen, you mentioned challenges of copays, and I think as we're all contending with future challenges with insurance coverage and maybe people losing their coverage, can you comment on strategies to address copay, things like the $4 medication list, other things that you have encountered that can be helpful in those situations?
Yeah, so that's a great question. So the question of in the era that we're living in, I think a lot of people are worried. I am worried about people losing medications, not just for HIV, but for all of their conditions as well. And so something that I've been thinking a lot about too is, many of our patients may just not even be aware that they're not thinking. They're thinking about other things that they're losing and not thinking about kind of their chronic daily medicines. And so as providers, I think there are a bunch of things that we can think about. One is being able to try to, towards the end of this year, ensure people have larger supplies of their medicines. And so that includes, if you can, prescribing a 3-month supply, prescribing a 2-month supply, encouraging people to kind of like nudge their refills a little faster that they can, if they can pick it up a week early, just kind of stockpile their medications. And then there's certainly just, people are going to run, if they lose insurance, they're going to run out of medicine. And so at some point, people may have to pay for things. So again, as providers, I think that behooves us to ensure that we are aware of what is cheaper. And so generic drugs are usually cheaper. We may have to switch people off. Fancy medications that are specialty medications may be very inaccessible to our patients. And so kind of going with the basics. And that's where, people like myself and Janet can be helpful with that and trying to figure out what costs might be, adding up the costs for people, and then utilizing any discount programs that are available, like GoodRx, that are like not insurance for medications to, again, try to lower that cost. So I've been thinking a lot about, from the 3-pronged strategy of making the patients aware so they can advocate for themselves, us as providers ensuring that we do as much as we can to try to get people as many of their medications as they can in a pile, as well as thinking about what are the next steps in terms of lower medications, doubling the dose if it can be cut in half, so that also doubles the supply. So there's, some tricks and tips we have up our sleeves to try to strategize how we keep our patients safe with their medications for kind of the short term until stuff hits the fan, and then kind of afterwards as well. It's not a great situation, but we just got to do the best that we can.
Thanks. And the Costco Walmart programs,
Yep.
$4 a month or $10 for 3 months. Those
Yeah.
things could be helpful to review
Absolutely.
those lists.
And then no Costco membership required to use Costco Pharmacy.
Other questions?
Thank you, Janet and Jen, for this wonderful presentation. And also thank you for the shout out to Ask Your Community Pharmacist. I did want to add one other thing with this copay dilemma that we're facing at the end of the year with insurance companies. So to think about the organizations, the community-based organizations that you currently work with, because they have patient assistance programs. And so for those of you that don't know me, I'm with Mission Wellness, and we are now a nonprofit under Primary Care at Home. And we have, our organization is planning a copay assistance to help patients that are part of our current case management program. We offer wraparound case management that is not, it's in addition to whatever case management the clinic is. So just to think about the community-based organizations, because they do have copay assistance programs set up.
I also wanted to add kind of, this is also, we're thinking a lot about this for our long-acting injectables. And so two pathways, right, to obtain long-acting injectables: pharmacy benefit or sort of clinic billed medications. And so as people sort of lose their insurance, kind of just thinking ahead, right? What are people going to do about their antiretrovirals? Very unlikely they'll be able to access long-acting injectable therapy if they're out of insurance. And so really thinking about what are the strategies for oral, switching to oral if needed. Right now, I think we're dealing with a lot of diabetes, GLP-1s, things like that, but also all of our chronic disease medicines we have to think about.
Great. Okay. Well, I think we can go ahead and wrap up there if there's not any other questions in the room. I want to thank both Janet and Jen for amazing talks and for really teaching us about these complicated medication issues. Thanks.